So there it says we are now recording. Once again, thank you very much and welcome. Mostly now we have gentlemen only. Um, we hope that those who look better than ourselves will be joining in, as their input is very much valid. On the panel, we had Funkai Ndemera and Philippa. Those were also then going to represent the ladies. And the interesting thing about them is they were also not medical professionals per se, or they're not in doctors. Philippa is a respiratory care practitioner in the States, and then Philippa is Fungai was trained as a nurse in Zimbabwe, but she's currently working as an entrepreneur in the UK, and she is working with some nurses that are there. So hopefully they'll get to join in on later. So what brought us together, or what brought about this conversation? I'm just going to share something here. This was a tweet that was sent out by, I hope everyone can see it. It was a tweet sent out by at Adam Theophilatos, who is a Zimbabwean working as a journalist in the UK. I reached out to him to try and see if he could spare some time so that he can also join the conversation. But this is some statistic that he then shared, and it was then Dr. Bazara who then shared it with the doctors on the WhatsApp group, and then it's just something that it inspires a lot of thinking. So as it says there, that the NHS in England employs almost 4,000 Zimbabwean health professionals alone. That's a big number, and it's more than any African nation except Nigeria. And then he then asked the question that imagine the impact that these men and women would have on the Zimbabwean economy, particularly if they were going to come back. And then the question then becomes, how can we get them back? Though that's a very high figure, 3,909, and it's only second to Nigeria, which has 5,000 there. But if you look at that, Nigeria has a population of over 100 million people, and little old Zimbabwe is just over 15 million people. Then it really shows that there's a high number of our people, our qualified health professionals there in the NHS in the UK. And it even becomes more alarming if we then contrast it with our setup here, where we have an underfunded, yet overburdened health system, which is also quite understaffed. The WHO recommendation is for a doctor, the population ratio is 1:1,000, but in Zimbabwe it's 1:12,000. Every year we have doctors who qualify in the hundreds. We even now have 3 medical schools in the country, with the University of Zimbabwe, the medical school at NAST, and then also MSU coming in. And I think it was only last week where we were seeing some medical students who are celebrating that they've qualified. As far as nurses are concerned, we have a nurse training institution in every province of the country, and those are churning out nurses in the hundreds every year. Yet we don't see them in our hospitals, and they seem to be disappearing and going to other countries. So it then brings in the question that what's going on? Why is it that they are leaving? How is it that we can get them back? One of the things on the minister's 100-day agenda, as part of this new dispensation that we are in, that every minister or every ministry was tasked to come up with a 100-day plan. One of the things on the Honorable Minister of Health's plan is to engage these health professionals that are out there in the diaspora to see how they can come back in. So our discussion here is to kind of maybe in a way assist that, or explore some of the factors that are behind such kind of statistics. So on the platform, I'm grateful for having Dr. Charasika, who's here. Dr. Charas is currently working as a management consultant at McKinsey & Co. Despite having been trained here in the UZ, that's where he has found himself at contributing lots through his brilliant mind to many African countries. We have Dr. Tinashe Maduke, who's working as an internal medicine resident in the States there in Washington. Then we have Dr. Sid Konweshuro, who is a local GP based here in Harare and an entrepreneur, someone who's quite vocal and active as far as Zimbabwe is concerned. Then we, as I mentioned before, that we're expecting some more to be coming in. Dr. Chireka, who is a GP employed in the NHS, one of those very people that make up that statistic of 3,900 Zim health professionals in the UK. He'll join us when he's able. And then Fungai Ndemera and Philip Asband. Then we also have grateful to have doctors who are based here in Zimbabwe, who many of them have decided not to leave, or maybe are in the process of trying to get the papers to also then join those in the diaspora. So it should make quite an interesting conversation. I'm Dr. Marlon-Ralph. For those who don't know, I'm an e-health specialist working for a technology company that is part of the Econet Group, where we're just trying to explore this new field of medicine that's called e-health, to leverage on all the ways that technology can contribute to the health agenda. So with that background and what we're having on the screen there, I guess the first question is kind of like, why is it that people leave? Those 3,900 there, why is it that they left? I think that kind of then gives some understanding as to how we can also kind of get them back. So maybe starting off with you, Dr. Sid, you are here. Why didn't you leave? Or did you try? What's your opinion on the push and pull factors? Hello? Hello?
Microphone. Can you hear me now?
Yes, we can hear you now.
Awesome. Okay, so people leave for the simple reason that, well, for a number of reasons, but I think for a lot of that number that we see, the 3,900, people left for economic reasons. So you spent all these years studying, over 13 years, studying, and parents are paying. And at some point you're expected to be able to, contribute back to the family that spent so much money in taking you through med school. And what was happening is, unfortunately, the medical industry or the healthcare industry is not exactly a profit-making industry, so to speak. And it depends on the viability of an economy. If an economy is not doing well, it becomes very difficult for government to, say, pay competitive salaries and things of that nature. So when an economy tanks, doctors can't exactly expect to get paid huge amounts of money when the economy just doesn't have money. So people left for economic reasons. A lot of these same people have continuously looked back over their shoulders over the years because their hearts are home. They want to be here. They want to contribute. But at the same time, they've got to be able to provide for their families a standard of life that, shall I say, is commensurate to their level of training, and obviously comparing with other doctors in the region and the rest of the world. So that really is where the problem starts. I have my family. We've got a couple of doctors in my family who are in the UK. I benefited from their being in the UK. I had the luxury of staying because they were supporting me. And I had the luxury of dreaming that I could actually put my hands on deck and help rebuild the system back home because I had the support of those that left. But then you realize, and I said to myself that, look, we can't all leave. Somebody has got to try and stay and try and rebuild, because we're very good at picking out what needs to happen or how to increase efficiencies. But there is not enough that are willing to actually put their hands on deck and shoulder to the plow, like they say in this new dispensation, to actually say, how can we actually help the government? to create a health system that is economically beneficial to the doctor as well as affordable to the patient. And this is why the work I'm doing right now is a medical insurance company. We're trying to set up an affordable medical aid company to allow as many as possible to come on to affordable medical aid, to be able to create a pool that allows them to access services, but at the same time, you can actually afford to pay the doctor. So the question of how do you finance the health system is a huge question that needs to be answered by the creative minds that are here.
Thank you there. So to you, it's comes down to that basic, thing. It's bread and butter issues. People need to take care of their families. Dr. Maduke, you are in the States. You were trained here at the UZ, where all great doctors come from, and now you find yourself is it in Washington?
In Louis,
it's St. Louis. All right. So what brought you there? What were some of the factors why you had to leave?
I think my story is a little different. I had more family factors. My wife was here, so it was one of those situations where I had to make that decision, as well as an opportunity that afforded itself for me to come to the US initially on a global health fellowship program. So initially I came here on a global health fellowship program, but then my wife was here, and then I ended up pursuing a master's in public health because I was always interested in doing public health and mixing that with being a physician. And then I did the exams, and I'm doing my residency here in internal medicine. But again, one of the things that is very clear for me, and I think for a lot of other Zimbabweans and other people from other countries as well, is that we all want to go back home. One of the things that I'm working on a day-to-day basis is how can I get myself to fit in and get back to Zimbabwe. Everything in my head spins around that. And I think having a platform like this is important for us to share those ideas and thoughts as to what can allow people like myself and others who want to come back home. I meet a lot of Zimbabweans, we have our gatherings, we have our meetings, and that is always a common theme. Everybody talks about wanting to come back to Zimbabwe. The hardest question is how. The hardest question is how do we get to do that? How can we make a contribution in Zimbabwe? And for that contribution to be recognized and appreciated and to see that there's a willingness to get people involved back home. And I think the new dispensation allows for us to start talking about what does that actually look like? What are those platforms? I don't know if you want me to, everyone's still kind of talking about their own story. So I'll say my ideas after everybody kind of chips in on where they are.
Yeah, that's what we're interested in those ideas, and we will get to them shortly. You said that the general feeling is that people want to come back home, but whilst we're here, the kind of trend is that people want to leave. I know maybe the new dispensation has kind of turned things around, but if I just look at the number of my classmates who have left, then the number who are now working in the NHS, working in Swaziland, in Australia, everywhere, it seems like the majority would want to leave. To you, Dr. Pazara, you finished your housemanship, you did your district, and then you have done all that is the minimum requirements. Why is it that you are still around, or are you maybe possibly working on also trying to join the great trek outside the country?
Yeah, well, I want to echo what Sydney said, that it was most of our health force, actually, especially those who have joined the NHS. It's more like they've gone in an economic mufekani, so to speak. They joined that race because, from what he said, you live because you want to get a living, isn't it? People are sacrificed for us to go through med school. For some of us who went through med school during the difficult times, 2008, I was in the junior times at med school. So, you know, you'd want to see what you work for, and even for those who have sent you to school, they want to see that you're a doctor, you know, you are in a family, and people are saying, okay, you're a doctor, and you have 2-3 people to look after, young brothers, sisters, you know, that African setting, you get it, isn't it? And if you're a doctor, you're carrying the torch in the family, they expect you to send even the younger siblings, nieces, you know, nephews to join med school. And how much is it? How much is it? Are they charging at the CHS at Paris? You know, you need to do that. As for myself, you know, it's about I'm a family man. I thought to myself, if I join the trek across borders, then I was going to take care of my family here. You know, it's about upbringing. You know, it was going to be a selfish move for me to be up there. Probably economically or financially, I would be at some level. But, you know, there are other values that you have to put in life besides the financial muscle. And, well, I can't safely say I'm working on leaving Zim, maybe to study, but not necessarily to settle up there. You know, it struck me. That's the reason why I put it on that platform with more than 250 doctors. Why almost 4,000 Zimbabweans are employed by the NHS? I mean, we're just talking of the UK, isn't it? Talk of Namibia is the current magnet to the health force in Zimbabwe, the junior, especially the junior cadres. Namibia is a Southern African country. What is it that is being done there that we can't do here in Zim? That's the, you know, that's the question. We can't even take it to the NHS. It's far away. Yes, yeah. It was some statistic that was put on some tweeting platform. But I thought to myself, well, how many Zimbabweans are there in South Africa, Lesotho, Swaziland? Talk of Australia, Canada. I mean, in the States, you know, we have gentlemen here who are based in the States. Yeah. The real answer, I mean, the probably a substantive answer to say I'm in the diaspora because of this and that. Many people may not be able to give a one-way answer to that. But well, I'm a bit worried. You know, I thought to myself I need to really share this with my colleagues. There are probably 5 prongs that I was looking at, and to which I thought we would discuss on why. Are we all thinking we're in the wrong place? You know, most professionals, not just doctors, not just nurses, not just physiotherapists, not just clinicians. I mean, most people, they just feel that they were born on the wrong side of the fence, being in Zim because of the economic decay and you know, that political landscape that is not even, and which is quite turbulent. I mean, probably there are some game changers that we need to bring in Africa, not just in Africa, but in Zimbabwe, basically, you know. We talk of healthcare financing, you know, supply chain, human resources themselves. I mean, for investment, you know, and digital technology. Right now, we are interacting here on a digital platform. If you go to many hospitals in Zimbabwe, talk of central hospitals, Parenya-Twa, Mpilo, UBH, Tungwizara Central. You know, you won't see much of that digitalization that is there in terms of patient records management, patient flow, data flow, and even management of funds and other things. You don't see that. And that's a simple thing that we may say, well, a patient who's coming from deep down in the rural areas in Zimbabwe, what would they benefit from a digital, say, digital filing system that is available in the NHS? Look at that. But it is one area that is probably, from what I've just said, I mean, those 5 areas, look at supply chain. You know, say, for example, Paranyata wants to procure some drugs from some pharmaceutical industry. You know, they have to get people to walk down streets, go negotiate for these tenders and that for things that can only be that can actually be done over the phone, you see? So some of those things, you know, they are hindering, you know, progress, so to speak, when it comes to healthcare provision. And at the end of the day, you know, besides financial benefit from going across borders, you want the ease of doing business and the ease of executing your duties in any fraternity, in any business fraternity. whether you're even a vendor, you have to position yourself in a place where your merchandise will sell fast, and I mean you have the clientele base, and looking at the returns. So beside the financial benefit, in Zim we have a lot of challenges and hurdles that we need to overcome before we can bring our folks home. We have a lot to do. Personally, I feel I'm a Zimbabwean. I should bring service to the Zimbabwean. But many times, you are overburdened by lack of, so many things that I've highlighted to earlier. Lack of even an assistance. Sometimes we don't talk of drugs, consumables, surgicals, and we can't even talk of salaries and wages. I mean, those are way below expected standards by any nation that is poised for development, as we are in the current dispensation, as you were saying earlier. I mean, we need to implore and explore other avenues, and not even looking at the NHS. As I am saying, NHS is too far from us. Take, for example, systems. How are they doing it in Swaziland? How are they doing it in Lesotho? I'll always give the example of Namibia, which I think the first group of doctors that they produced graduated this year, if I'm not mistaken. I mean, but their health system is quite on point. I mean, looking at the services that are provided to the general population of people, and also looking at the health business itself. Many Zimbabweans, they are making a killing there because they're actually making use of the skills that they acquired here locally, and they go there, export that that knowledge. They go establish good centers, good service provision. They actually, prey on public service, the medical aid society that is in Namibia, and they're preying on that. And those are some of the things that we're saying. Why can't we do it here? What is exactly the problem? Is it because it's us attitude, or is it because of the economic durable that is against us, that we should fight against? I mean, there is more that we can actually explore.
There's indeed more, and as you said, that more needs to be done. When you already jumped into the, some of the things that are there out there in the diaspora, that what we don't have here. And as someone once said, you went in it, so there's still a lot of work that we need to do. Now, just coming to you, Dr. Charasika, one of the questions that was raised by that tweet. The focus for everyone now is on our economy. And there you were saying, imagine how these health professionals in the diaspora, how much they can contribute to the Zim economy. Even the president said, the main emphasis or the main focus now is economy. So I'd like to hear from you. What would you say are the ways that these guys can contribute to the Zimbabwean economy, or maybe even ways that they are currently contributing to the Zimbabwean economy?
Thanks, Doc. So I'll start with what they're currently doing, and then we can take a look at some options and opportunities for those in the diaspora. So I think currently the majority, and I'm sure anyone who's in the diaspora, sends remittances in one form or another. Whether it's directly to a parent, a relative, a child. I think that's the key thing, and that's across all sectors, not just health sector, but I think all our diaspora are sending remittances. We know that's the biggest form of foreign aid that we have in the country right now, is actually our remittances. And then you will get the occasional few people who are actually doing a couple of investments. I think about a month ago, I was reading about a lady who opened a maternity clinic in Waterfalls, I believe. So you are getting a few people who are doing more active investing. But that's a tiny drop in the ocean. And so I think that, there's a number of opportunities that people in diaspora can be thinking about in terms of contributing. So, ideally would like them to come back, but that may not always be realistic because of family commitments and where they are in life. And if I'm very honest, I think as my colleagues have mentioned, Zimbabwe is not yet able to offer an equivalent lifestyle, an equivalent level of opportunity, whether it be business-wise or education for your children, or even just your own career growth. Zimbabwe is not yet at that stage. And so that keeps a lot of people out. Now, if we can address a lot of those things, then I think people will start to trickle back in. But in the meantime, I think there are a number of things. So I think number one is just looking at investment. You know, if the leadership that is there, if the leadership will really take a visionary, futuristic look at our healthcare sector, I believe personally that Zimbabwe can be like a Dubai or a Singapore or an India of healthcare. Geographic location, we're well positioned. Countries can fly in from all over. But also we have the people with the skill set and the entrepreneurial ability. Now, what is required is leadership that will create that enabling environment. And I think that's been one of the lacking things. I think my colleague talked about the ease of doing business. Starting a healthcare business in Zimbabwe is one of the most complicated and difficult things to do in Zimbabwe. I think we know a number of healthcare facilities which haven't taken off, which are still lying idle and things like that. So we need leadership that is willing to, you know, open the pathway and create that opportunity. What that does is that Diaspora can then actively invest. I was recently in Ethiopia, and the Ethiopian healthcare diaspora put together a $100 million fund to build together a state-of-the-art hospital in Addis Ababa. Right? These are doctors, nurses, professionals who are abroad. They all bought shares into this company, and they've put together $100 million to build the state-of-the-art facility. Now, there's no reason why us as Zimbabweans cannot do that if we have the right business frameworks and, of course, the right legal protections for everyone in that place. So investment is number one at large scale, but even at small scale, there's no reason why I can't link up with my former colleagues and say, guys, let's put together a medical center in Zimbabwe, and we get that going, right? But again, you know, a number of other factors, it's a big story. You have to look at financing, who's able to pay for this care, and all those kinds of things. Number two, another big contribution that a lot of our people out there can do is philanthropy. I call it philanthropic investment. So people can pick clinics, pick health centers that they like, and you know, there's lots of equipment out there that can be used and repurposed in Zimbabwe. We're not talking about broken down equipment, but oftentimes in the first world, countries always want to be on the cutting edge, and so they'll get a new X-ray machine when the old one is 1 year old with a 5-year lifespan, right? So if we can begin to create those kinds of partnerships and linkages where we're getting some of this equipment coming across to Zimbabwe, and again, the challenge is to the authorities to make sure that this is possible. One, from the duty perspective, don't make things complicated. From the authorities that do regulatory, yes, they need to regulate. It's important. They need to make sure we're getting the right kinds of equipment, but don't put red tape in the way. So people can then begin to gather resources wherever they are and send them back home. And oftentimes the hospitals and the facilities that people are working in diaspora are quite willing to help if someone will take leadership and say, look, I come from this district and I'd like to help my district hospital. So please, can I get that piece of equipment which you're stepping down and getting a new piece of equipment? Hospitals are often willing to help to do that. But we need leadership of the diaspora itself. And then on this end, we need leadership to be able to mobilize and get that running and in place. The third thing that I also see as an opportunity for a lot of our diaspora is participating in research. So I think one of the big things that's lacking in Zimbabwe is we do not do a lot of research. And what you will find in a lot of the developed countries and countries that are moving forward is that there's a lot of medical, clinical, public health research. And what that does is it pumps money into the system. It often upgrades the equipment and upgrades the services that clients are getting. And so two things are happening. You're generating new knowledge, but at the same time, you're also getting new pieces of equipment, new services. So I'll give you an example. If we think about obstetrics and gynecology, we've got big research grants going on in Zimbabwe. And what that's done is it's helped Mbiyanahanda Hospital to be a little bit more functional. It's not where it needs to be, but it's a little bit better. And that's because research grants have come in. Similarly, with the medical school, we've got a lot of the big research grants that are being run by the professors there. What those have done, they've put Wi-Fi all over the medical school, they've put computers in the medical school. And so these are things that can be replicated all across the country, that the diaspora, who may not be able to come back for various personal reasons, but they can have that linkage and facilitate those kinds of things. So that's really critical. I think the other thing that the diaspora can really be doing is helping to build the skills base of Zimbabweans. And so, we have people here who would like to do things, but we only, for example, I'll take surgery as an example. We only have a limited number of surgical specialties. There's a number of surgical things that we cannot be trained in Zimbabwe because we do not have the professors to train us. And so someone in the diaspora can be facilitating something like that, get people coming across, they spend a year, 2 years, and then they come back. And the question is, will they come back or not? But we'll assume goodwill, that people go there and they get trained and they come back. And what that does is that you're creating more services in the country. And so that by that, you begin to create this ecosystem where people aren't necessarily having to fly out to get services, but they can now get the services in Zimbabwe and begin to generate revenue. And that grows our economy. I'll give you an example. In the early 80s, Paranyato Hospital was the referral center for Southern Africa. If you take out South Africa under apartheid, basically Paranyato, the way it was built, was meant to service the federation. Zimbabwe, Zambia, Malawi, but by default, it ended up also serving Mozambique and Angola and DRC. And so even up to the late 90s, what you would find is that people were coming to Zimbabwe for chemotherapy because their own host countries did not have chemotherapy centers, right? So we need to get back to this place where the diaspora, either themselves coming back to be very super specialized, or alternatively helping people to train, because what that does is also starts to build the medical tourism industry, where people from around the region are coming for specialist services, which they can't get further abroad. But again, it's a cocktail that requires a mix of financing, requires a mix of leadership, it requires a mix of getting the right infrastructure in place and the right equipment. But again, I put it down to visionary leadership. If our leadership will look into the future and say, we want to have a healthcare system like India, where everyone's flying in from the globe, a healthcare system like Dubai, which is state of the art, you'll find people coming to spend money here. Our people don't necessarily have to go out anymore, and so they keep money here. And that's how I believe that we can grow the economy. So the diaspora is critical. They are seeing things that we are not seeing in Zimbabwe. They're seeing state of the art care, which we are not seeing in Zimbabwe. And so if that is brought to Zimbabwe, I believe that it can leapfrog us to the front of the line and everyone coming in to get the services that they need.
Great. Many factors that you touched there: need for investment, need for ease of doing business, the need for leadership. If I may go back to you, Dr. Maduke, we may also just kind of add on that. You are in the diaspora there, and if you were going to come back, what would what are some of the things that you want to see here, in addition to what Dr. Jessica said?
I think for me and probably several other physicians or health professionals in the US, I think there's several things that can be done. Number one is, of course, the platform where people can come back. But one of the things one can do is creating, for example, speakerships and people coming to the medical school, or, get a pulmonologist or gastroenterologist doing the sessions that they can come down, do a week's training on maybe a procedure or maybe a treatment plan or updates on heart failure management, and getting people to come in and doing some of those things. I think people will be interested in that. One of the things that I noticed here is they're what they call EICUs, right? Where you have ICUs that are manned remotely, almost like telemedicine. And what that does is you have an ICU attending who's sitting in St. Louis, but he's monitoring patients in California. I have one of the attendings that I work with here, and she's licensed in 50 states, in all 50 states in the United States. And she watches patients right here in St. Louis across the whole of the United States. And I think of that and I say to myself, well, all they need is internet, right? That's the only thing that they need. They have internet connection to all these hospitals in different parts of the country, where this ICU attending is sitting down, looking at the monitor, looking at the lab values, looking at the vitals, and giving instruction over the internet. Of course, that requires a stable internet connection, etc. But that's an example of something that can be done in terms of creating infrastructure where you can have that instruction being done over a reliable internet connection. Maybe getting the ICU at Patio at UBH or Mpilo, and setting up a schedule and say, hey, can we have one guy, donating about 6 hours of their time to just kind of help man an ICU, get a whole collection of Zimbabweans who are ICU attendings, or even just training, just having a live connection to, I don't know if the medical school is doing that right now. They may be doing it, I'm not aware. by creating a session where you can say, okay, the medical students are learning on cardiology, and having a cardiologist, Zimbabwean cardiologist, say, okay, can you donate an hour of your time or 2 hours of your time to sit down and just through Skype offer a teaching on whatever cardiac topic it is, whether it's heart failure management or atrial fibrillation, anything like that. And you can allow for people to have, to commit to set times of contribution. And they can say, hey, you know what, I know this week I'm scheduled to do this training session or give this talk. And that would be beneficial for medical students back in Zimbabwe. I think the tourism one is also very interesting. I've always thought that Victoria Falls is a beautiful example of a place we could use for that, where you create a state-of-the-art facility right close to the waterfalls. And you can use that as a tourism hook to say, hey, you can get your hip replaced and spend, a week of recovery, in Victoria Falls and safari or whatever it is. And you can get people to come down to do that. You can get surgeons who can come down and do their cases. If that center is accredited and recognized worldwide, people can fly in, get their procedures done, enjoy a week at the Victoria Falls, enjoy a week in Yanga, wherever it is. And that will be a state-of-the-art facility, and we'll charge a premium, of course, because people want to come to a place like that. They're willing to pay money for it if there's value that they get from it. You look at in the US, the cost of a hip surgery ranges anywhere from $15,000 to $75,000, $100,000 for just a hip replacement surgery. And if I think to myself, if I can get the same procedure done in Zimbabwe, say for $10,000, and then I get to spend a week at the Victoria Falls, and then I get to learn a whole new culture, and I come back to the US and it costs me $30,000, I suspect a lot of people would want to do that because they do that already. They go to India because it's too expensive for them to do the hip surgery here. They go to Mexico. And that's why the whole concept of tourism is a brilliant idea, because it doesn't cost much. Even getting the surgeon to fly down to Zimbabwe will be like $2,000, $3,000. It still will be miles away from what they would be charged if they're doing it here, say in the US or maybe even in the UK. I don't know about their system there in terms of cost, but I think that's an avenue that's definitely worth exploiting in terms of getting people involved.
Yeah, thank you there. I think you mentioned something that is also kind of like my language, technology and telemedicine. If we look at telemedicine, it's not only the provision of diagnostic or curative services using ICT, but even something as as health education. So what you're talking about, having a specialist or an expert who is out there in the UK, in the US, but who through ICT, through platforms like this one, is conducting a lecture for medical students, for nurses, that is classified as telemedicine, and the technology now enables that. I've heard that there are some lectures that are being organized in such a format, in psychiatry, as well as I think cardiology, because of the relationship that we have with the guys in Denver, Colorado. But that's what technology is enabling. And to even take it further, it now seems like from what you're talking about the doctor who is an internist, but she's just based at one place, but taking care of people across the country. So with technology now, I guess maybe the question is, we don't necessarily need these specialists to kind of come back. What we are trying to look at is how they can contribute from they are. We know the ministry is spearheading telemedicine. They are conducting a pilot in Manicaland, which they are aggressively pushing forward. And it then allows for a radiologist, a cardiologist, a dermatologist, or even a psychiatrist who's out there in the diaspora to be able to serve patients here in Zimbabwe. And this will be, a service that would be easier because they are speaking with people from home who know the language, who know the culture. So technology can kind of enable that. But now, just if we are to put ourselves in the shoes of the minister, that, you know, everyone is pushing a 100-day plan. We know that all of these things won't, you know, change in 100 days. But are there some, you know, some low-hanging fruits, things that can be done now, that can be implemented in the short term, that will then enable these colleagues of ours out there in Namibia, Swaziland, or wherever across the globe to contribute to the development of Zimbabwe and even the economy of Zimbabwe, because that is the focus. Economy, 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 as the president said. So this is an open question to everyone. What would be your advice to the minister, like something that he can implement in the short term that could, you know, give us some results?
Yeah, look, you know, the healthcare system for me is like a ship. It's not like a speedboat, right? So a speedboat, you can kind of turn it left sort of immediately, whereas a healthcare system, you know, you kind of have to go, you know, 50 Ks and then start turning the thing, right? And so I think that's one of the challenges that the minister has in his 100-day plans, is what are the quick wins that can be done in a thing that's been sort of straggling. So some things that come to mind, I think the critical things for me, they may not be visible, and I think they would not be visible to the person, to the naked eye, but I think a lot of policy issues. I think policy that are directly within ministerial control can be immediately addressed in a 100-day plan. So what are we talking about? We're talking about creating investment-friendly policies. So if you're a diaspora and you're out there, there's a way for you to get your healthcare-focused investment into the country, right? That's him getting together a team of people, think through it, have a call, dialogue with diasporas, what kind of investment platforms they'd like, put that together. That's directly within his mandate. He can get that done in 100 days, right? We're looking at one of the biggest complaints I've heard from people trying to come back to help is there's so many hoops when you try to come back to Zimbabwe. It's like almost impossible. I've had friends give up and just say, okay, you know what, I'm going back. And so I think there needs to be a way to do a rapid appraisal, rapid assessment of people who want to come back and serve, whether it's short-term, long-term, or permanently. Shorten that process. Yes, they still need to be screened. We need to make sure that people are safe to the public, but we need to make sure that that process is user-friendly. And I think that's something that if he sits with the MDPCZ, they can very quickly come up with a new policy that allows people who are coming in to come and serve, to come and lecture, to come and help. And I think that's a big, quick win that the minister can help. The other thing, again, is a really just basically for him putting out a call. I think one of the things that we're struggling from is pride. You know, we don't want to be seen as a failed state. We don't want to be seen as we have not been able to do this. But if he was to very quickly say, look, these are the top 10 priorities that we have in the country from a public sector perspective. And we're calling out, this is a call for help to our diasporas and to friends of Zimbabwe. And this is how you can help. I think he can very quickly put in place the platforms to help. So as an example, we know there's a lot of problems at Harare Hospital. And that's very easy for him to sit with all his hospital CEOs and say, guys, what are your problems? And which things are resource challenges, or which things are challenges which, you know, we're not being given enough money as a ministry, but there's people out there willing to help. Put that list down, put out the call and say, hey, guys in the diaspora, this is the issue, come and help us. I think people will very quickly jump in. But because that call has not been made, right, people, one, do not know, and then two, when they do try and take their own initiative, a lot of roadblocks are put in front of them. And it's seen as a political move. It's seen as, you know, trying to show off whatever, when actually it's people just wanting to help their fellow citizens. And so if the minister can put in place those kinds of platforms and opportunities, I think very quickly we'll get responses of people coming in. They may take, the actual action behind it may take longer than 100 days, but I think the policy frameworks can be put in place in 100 days.
Great there. The 2 Ps, address policy, address pride. Any more contributions as far as, you know, suggestions to what the minister can do in the short term to rope in our colleagues in the diaspora? It's open to everyone. Yeah.
Okay. Great. Yeah. So I think those are the key things that Faraz just mentioned. There needs to be an environment that allows for this kind of activity to happen. I'll tell you, in the last couple of weeks, the number of people in the diaspora who have sort of tried to reach out to me and say, where do we start? I mean, I've got one guy, you know, he tells you the sort of skills that he has from a public health perspective. And this sort of stuff that you can do is like, who do I call? Where do I start? So I think what the minister can do immediately is to create an obvious conduit to say, look, you want to assist? There's this panel that's right here. This is how you get in touch. Tell us what you can do. But also it helps to guide the contribution, like Farai says, what are the top 10 priority areas and how can you come in? That roadmap has got to be clear. And I think that clarity comes from clarity of policy. People have to be clear what you're trying to achieve, and then people know where to fit in. Number two, I like the concept of, look, you've got to, I think we've got to find a way of monetizing this contribution, because everything is tied to some kind of economy. So if the radiologist, I've got a brother who is a neuroradiologist in the UK, and he said to me for the longest time, I can read some of your scans. I want to teach as well. Can you create some kind of financial benefits? So if he says teaches 10 hours, there's money that he's been trying to send home. Can we just pay that money out from here? So now he's actually working and knowing that, look, I usually send $1,000 home, but with 3 hours of contribution, that money is actually taken care of. There's actually money that's paid, and you can then bring in private medical insurance companies and things like that. These guys are collecting tons and tons of cash, and say, look, can you, as part of corporate social responsibility, donate X amount towards this sort of thing? Then you now have this thing beginning to roll, and as it goes, you actually begin to advance and actually, sharpen the skill and sharpen the whole project and how it works. So people want to come back, that there's no doubt about it, but no one is leading the revolution. No one knows where to, and that's where the minister needs to step in, a very strong leadership core. We've got to look up to him. We've got to know, I've got to know I can get to the Minister of Health and either see him or whoever is responsible. Right now, I think it's not clear. Who do I talk to when I get to the ministry? Who do I attend? Who is the person responsible for this sort of thing? So I think this sort of discussion is key and needs to be on the minister's desk as soon as possible to say, create obvious conduits for people to say they can call in, and this is how they can contribute. And these are the 10 priority areas, and then we begin to move that way. And we then come in from the private sector and say, what can private sector do? Private sector needs to reach out as well to this diaspora and say, look, guys, can you do ABC for us? And this is how you benefit from it. This is how we protect your investment. That's key.
You just brought in something there that, someone else wanted to contribute. Go ahead.
Yes, I wanted to contribute regards locally in terms of the local system, how the healthcare is viewed. It should be viewed, healthcare, even in the public sector, it should be viewed as a business. In the past, the culture has been that to say that healthcare is sort of like more like a social service, and everything should be funded by the government. But currently, at the moment in Zimbabwe, it's a bit. We've got a bit of an unusual system where much of it is much of the programs are donor funded. So another thing is to strengthen local systems and view healthcare as a business. If you say you talk about user fees at hospitals, that has been a very huge bone of contention, and that stance and policy needs to be revisited so that institutions strengthen their own revenue collection systems, and the appropriate manpower regarding revenue collection is strengthened. If you look at the education sector, here in Zimbabwe, we do not have an education for free for all. It's not like that, because we saw that in the long term it would be unsustainable. But if people are to think of the same thing in the healthcare system, it's like an anathema. People do not want to think of it that way, that people should pay at all for healthcare. But for our systems to be self-sustainable, at some point, we also have to revisit and relook into that and say, you know what, we have to take care of ourselves. Because now time and again, you hear that this donor is going to pull out, and there's going to be a potential disaster. For instance, you talk about somebody who was funding blood coupons for maternity, and you hear that the donor is about to pull out, and there's a potential crisis in that area. So even talking about user fees and viewing public health institutions as businesses which run as their own entities needs to be revisited, and revenue collection systems for public institutions be strengthened. And that's one thing that has to be looked at, because borrow it, especially from the education sector. You can't say education for all. Why? It's unsustainable. And partly also in a government institution, if we can keep on saying everything is for free to everyone, it becomes also unsustainable against the background that the budget allocation to health is small. So while yes, healthcare can be quite expensive, but as a people of Zimbabwe, we have to pay for our own health system for the current period till such a time when our economy and economic systems are strengthened. But in the meantime, so that the institutions remain open and are sustainable, the healthcare has to be viewed as business, even in government. But that's a tough stance. That's a tough policy position, even for our government. But it really has to be looked into.
Mm. Yeah.
So I want to agree with Dr. Kadzinga, but with a caveat, right? And I think my comment here is I agree that the health system needs to run as a business from an operations perspective. So everything needs to be accounted for, every single Band-Aid, every single lab test, every single hour of manpower labor needs to be accounted for. Now, the challenge you have is that we have a population that is currently impoverished. And so many times they're not able to pay because they're poor. They're not able to carry the real cost. And so this is where things like your national health insurance comes in. Now, the challenge that we have as a country is that our country is broke. I don't know, we never want to say that honestly, but if we're honest to ourselves, the country is broke, right? Now, when the economy starts picking up again, one of the first things that needs to be put in place is the national health insurance. Because what that will do is it allows a healthcare provider, whether it's public or private sector, to charge, private sector charges with a margin and a profit, and public sector, at cost or a minimal margin, right? But what that does is that the national health insurance can then pay for service provided. And so what that does is it allows the hospitals to then become sustainable, as he's mentioning. So you need a balance. I think in any country that you'll find there's always a safety net for its citizens. It's never total. Even in the US, which is the most commercialized healthcare, there's still a safety net in the sense of Medicare and Medicaid. And so that I think that aspect is important. And so that's one of the priorities that that needs to be put in place. Now, tying this back to our conversation, how does the diaspora help? There are many health economists out there who are working, in Geneva, working private sector, in the big healthcare companies. They need to be coming to help us put this thing in place. How do we create a sustainable national health insurance that allows payment for services at the public sector level and at the private sector level that ensures that all our citizens get access to a certain level of care? And if you have more money, then you can get a higher level of care, and that's perfectly fine. But I think that's critical to ensure that that happens. Operationally, business, yes. Revenue collection, business-wise, yes. But let's ensure that we have a safety net for our citizens, because that is critical, especially at this juncture where our citizens are impoverished.
Yeah, great points, those ones. Unfortunately, I'm just looking at our time here. We'll need to be wrapping this up. But just maybe one last question from my side. Sid, you kind of mentioned it as well as when Dr. Kadzinga brought in the role that us who are here, who will remain behind, the role that we play, that there are various other people who are outside who are interested in coming back, but they also are asking us to say what needs to be done, how can we contribute. So that's my question there. How should the local health professionals, those that are in Zimbabwe, how should we position ourselves? How should we seek means of collaborating with our colleagues who are out there but are interested in contributing to Zimbabwe? Again, it's kind of open to the floor.
So I have a comment a little bit on that, because I think in as much as the Minister of Health has a lot to bear in terms of the responsibility engaging us as diasporans, I think it's also important, and someone touched on something very important, the MDPCZ as an example, and the hoops that people have to go through to register with the MDPCZ. And I know several people, I was talking to someone actually a few days ago, and that person is a gastroenterologist, and that person struggled to come back to Zimbabwe just to offer services. Just getting into a place like Pari, even pro bono, is a bit of a challenge. I heard there were some challenges with, I think there's some pulmonologists who are in Zimbabwe right now, and there are some issues with their registration. Now, I appreciate the importance of the MDPCZ, and I totally agree with the philosophy that we need to make sure everybody gets screened and everybody gets through that process. And I was involved when I was there when I was still in Zimbabwe, trying to facilitate the registration of some physicians from abroad who wanted to come and volunteer and to do some work in Zimbabwe. And I remember the numerous obstacles and challenges I had to go through just to get their paperwork involved. I mean, it's as simple as, for example, if the MDPCZ can have a online portal where people just submit all their paperwork of the things that they need to get done, without having to send it and post it to Zimbabwe, as an example. Second thing being, even the providers and our colleagues who are in the hospitals, some people feel, as diasporans, we feel as though there's an antagonism of, oh, you ran away, now you're back, And I think there's a need for that to also be somewhat addressed. I don't know how best that can be addressed, but one of the things that's important is, if people in Zimbabwe, providers in Zimbabwe have ideas or projects they want to do, or for example, research that they want to do, say, I'm thinking of doing this kind of research, and having a platform. And I think it's important if the Ministry of Health, for example, can set up a portfolio or a subcommittee on diaspora engagement. I remember back in the day, the RBZ did this whole thing where they got the diasporans to get involved to buy houses in Zimbabwe, and they were building houses under this diaspora initiative. And I think that same thing can be done with the Ministry of Health, where they create an actual portfolio or subcommittee or a department under the Ministry of Health that is going to say, be involved in engaging the diaspora, and create buckets and say, okay, those that want to get involved as diasporans and say research, this is the pathway you can go. Those that want to get involved in, say, creating businesses in healthcare, this is the pathway you can follow. Those that want to get involved in teaching medical students or our registrars, this is the platform, this is the pathway you can follow. And actually having designated people who handle those portfolios, and having that portfolio being somewhat an intermediary between the diasporan professionals and, say, the council or other authorities that people would need to register with to function and to offer services in Zimbabwe. I think that's important. I like the idea that Dr. Sidney mentioned about the radiologists being able to read. I don't know how much, health insurance companies in Zimbabwe pay our radiologists in Zimbabwe to read CT scans or read MRIs. But I know, for example, my hospital, I'm in St. Louis. After 8 p.m., our CT scans are read by radiologists in Australia, and I'm in the United States. And I think that's something that can be done, and you can actually create a portal or a platform where you say, it could be a public-private partnership, where insurance companies can say, okay, maybe they pay radiologists just in Zimbabwe, I don't know, $500 or $1,000 to read an image. And then you have that arrangement where a radiologist in the UK, a radiologist in the US or Australia or Namibia or wherever can actually read some of those images, maybe even for less the money or the same amount of money. And there's an account in Zimbabwe, people can actually get that drawn or whatever it is. I think people will be willing to engage in those kind of initiatives. I don't think it's much for a radiologist to say, okay, I finish my shift at 5 o'clock, and then I go home. And then Zimbabweans, they need some images, but I don't expect Zimbabwe sending 50, CT scans, because we are more judicious in how we use our machines. So even they can commit 4 hours of their time to read stuff, and it doesn't even require that much effort on their part. So I think the ministry creating that platform where it's a subcommittee specifically designed to allow for engagement of the diasporans, and you have those subdivisions of research, healthcare provision, teaching, whatever it is. And then for some of us that like to teach, we know I'm going this way. For those of us that want to do business, we know we're going this way. And I think that is going to be, that's something he can do in the next 100 days to say, okay, we're setting a specific committee. And then they can always, discuss how we can make it much better. But that's something that can be done.
Just a quick one there, that example that you were talking about, a radiologist reading images. And from what I was getting from you, that Zimbabwean who's in the diaspora can actually be paid in local bond notes. If they're open to it, maybe the money then goes to a relative who's here. There's no need for us to then, pay them the foreign currency. It's a form of service to say, I'm in the UK, I'm seeing Zimbabwean patients, pay me in the local bond notes in a certain account, and then, it can be administered from there. Gentlemen, I think we have to draw this to a close. But what I'm grateful for is definitely your participation and your contributions, particularly that, we came up with, I think, points that were quite clear as far as suggestions or quick wins that, the minister can take, the minister can, effect. Talking about number one, addressing policy, making it more friendly, addressing issues at the MDPCZ. We talked about, creating a clear way or a clear path that someone who's interested in contributing to the development of Zimbabwe can engage the ministry through. So that is either a distinct body or a committee, but some people who are just dedicated to do that, as well as they know they can easily direct people to where there is need. And I think that is something that can be implemented. And the third thing is just the implementation of technology, having various platforms that then make it easier to do business in Zimbabwe. Adopting technology such as telemedicine to enable those guys that are out there to still contribute immensely to Zimbabwe without even need for them to physically relocate here, but from where they are currently. I think that's something that is practical and it's doable, and as we'll try to get this message to reach the right ears, it's something that could definitely lead to some changes.
I have something to say there, Dr. Marlon.
All right. Mm-hmm.
Yeah, there is another area that we seem to have, we have accepted we have just called it reality anyway. You've talked of digital technology investment, human resources in terms of lowering the diaspora and also healthcare financing. But I mentioned the issue of supply chain. I mean, I'm still based in rural Zimbabwe. I worked in one of the most remote areas. I worked in Siakobvu district. It was more for charity. I was working there for a few months. I would say, and as a response to Dr. Kadzinga's slide, mentioned about health for health, free health for everyone is not sustainable. Very true. But yeah, you talked about the finance schemes that can be put in place, national health insurance schemes to try to cushion those who are quite underprivileged. But when it comes to supply chain now, I have questions. Why in Zimbabwe in 2017 are we importing salt and water? I mean, that's normal saline being made in South Africa, just across Limpopo. We can't make syringes, plastic. We can't even make needles when we are importing basically everything that's being used in the medical field. Not talking about CT scans, the machines themselves, but I'm talking of the consumer. What's the wage bill in terms of drugs? Yes, we have, incapacitated the pharmaceutical companies, 12 caps, dat labs, Zimbabwe, and other, but the, I don't know how as a long-term measure, how can advise the minister, how best we can advise him in terms of, addressing the supply chain. Believe you me, in every hospital, in every clinic, we are importing more than 99% of everything that we are using, right from drugs, consumables, and now probably we are almost importing. We are going to be importing even the human resources, themselves. I mean, I don't think that's sustainable in as far as we don't address the basic thing. Not just drug consumables, paper, stationery, everything, printers, ink. I mean, everything in the hospital is imported. Well, that could be something beyond the Minister of Health office, but it's something that he needs to probably discuss with the relevant authorities to try to address the supply chain in the field of medicine and the health delivery system as a whole, whether private, public, everything that's being used is imported. And the wage bill is obviously bloated in terms of getting. I just gave an example of normal saline, just purifying and making the necessary chemical requirements and put up something like that. We can't make that. And South African companies take out the Fresenius, in the German company, Bibron. They've partnered with these companies just right next door South Africa, and they're doing that. They are manufacturing their own fluids, and I mean, it boggles my mind to realize that 99% of everything that we're using is basically imported material. Some of it just across Limpopo. It's something that needs a big.
So that's an opportunity for Diaspora. Yeah. One sentence. That's an opportunity for Diaspora. Come with your friends, come with your partners, come with your business partners, set up the industry, come and make the normal saline in Zimbabwe. That right there, you've got access to capital, you've got access to the technical expertise. That's something for the Diaspora to tap into right there and do it in Zimbabwe.
And to add to that comment, just to say, one of the things that the minister can do, because that's bigger than the Ministry of Health, is to actually lobby for favorable tax breaks for companies that want to do those things. If you want to open a business in New York today, tax-free for 10 years, right? Now, we can't do that in Zimbabwe. But those are incentives that get businesses to get on board. Now, it doesn't have to be 0% tax, but something the minister can say, hey, as part of that whole conduit we're talking about, if you want to come to Zimbabwe to set up your business and provide much needed drugs, etc., we give such and such tax breaks or something like that. That can incentivize investment.
Just to contribute on that one on the tax issues. Just to contribute on the tax issue. Currently, the government has put 100% duty rebate on capital medical equipment, and medical supplies are actually exempted from tax as well. This was also again echoed and enunciated in the budget which was presented by the Honorable Patrick Chinamasa. It was quite commendable. So it's quite open and for investment from the diaspora. Just to add some fine salt, a grain of fine salt, I know I stroked the nerve by saying that people should pay. For the record, I work in Bindura, and I see some of the people who come, from the most poorest of communities. It's not like it has to be like the charge in private, but just those little $5, probably say user fees and the like, just strengthening systems on gathering on those. But we have to create a sustainable system in the end.
All right, gentlemen, I really have to now draw it to a close. Thank you so much. We really have gone through some very valid, relevant points that would strive to get into the ears of those that need to hear them. And, we will all then contribute towards the development of Zimbabwe, and that's what this is all about. My battery is on 2%, and it has been battery well spent. So I think what's left is to thank you very much. I thank you so much for participating in this platform, and we will work towards creating more platforms such that, because this dialogue really is necessary. It's not just talk, but the ideas that come up are really practical ideas that could change the face of this country. So I wish you happy holidays and a happy transition into 2017 for everyone, whether you are in Zimbabwe, you find yourself in the UK, in the US, in Namibia, Swaziland, wherever on this continent, as part of the great Zimbabwean diaspora. I wish you a happy New Year. Thank you, everybody, and good night.
Thank you, and thank you.
Asante sana.
We are going to 2018, not 2017.
Thank you, Dr. Nyagawa.
Thanks, everyone.
Thank you so much.